It's very nice to be here this morning with the two gentlemen we're going to be speaking with. Adam runs the healthcare division of LexisNexis, a very well-known brand in the healthcare world around data. And Dr. Michael Sook is the head of the Musculoskeletal Center at Geisinger, and a member of our board as well. And he was one of the first adopters of Doctivity Health. So both folks today with a deep knowledge of data and how it works in healthcare. Adam, let me start with you. You're leading one of the big names in healthcare data. Everyone knows about LexisNexis. Everyone talks about innovation and how to use data. When you look out, to your future and your products that you're bringing, what role do you see in healthcare and how data is evolving?
Well, it's a timely question, I would say, given the current state of healthcare. At the moment, there's going to be a lot of challenges over the next few years, especially if we keep it in the next three, for healthcare to do more with less. And I think this is an ongoing cyclical thing we all deal with as healthcare providers and technology folks. It's just been an ongoing cycle. So as we look to streamline process and improve quality of care and create better access and do all the things that we do on a regular basis, the reality is it's going to be more and more tech enabled. And I don't think we're ever going back. So I think as we go forward and you look at decision support models and patient access and patient education, as we move towards self-service more and more, as we deal with the shortages of providers, there's going to have to be this transitional window where we can educate people, because one of the biggest parts of health equity and access is literacy. So there's a big hole for patients and their families around understanding what benefits are available to them, how to access care, what happened that they were newly diagnosed with diabetes, for argument's sake, and how to deal with that new disease state, and to facilitate providers being able to do more care with less resources. That's the gap in the middle. So I think there's a big innovation curve coming, and you're seeing this sort of show up around the edges right now. It's small language models, targeted models in these spaces where we work. So rather than trying to use large language blanket models across everything, you're going to see more curated, focused models that help us do tasks in spaces. So if you need a model for care management, for argument's sake, you might see ones that are disease specific going. So small models for care management in diabetes and weight management in renal disease. Or you might see things around prenatal, postnatal new moms with babies, but ways for us to really start to automate, not necessarily the care, but the orchestration of care. We don't need providers to deliver the care, but the orchestration and back office and engagement with patients is something that we can automate relatively safely, that doesn't create a lot of risk, doesn't ask machines to diagnose and treat people, but does help them ramp and access and be compliant with care in a better way. So I think there's a huge innovation in that space, which is just pragmatic given the lack of providers and the lack of coverage that we're going to see for a bit here. I don't know, Mike, what are your ideas here?
Yeah, Adam, it's interesting you talk about small and large language models and the difference. And I like the way you kind of contextualized it in terms of specific disease state versus larger population models. I agree with you. I think that what is coming down the pike are innovations with regard to, I think, workflow. And the reason I say that is because you point out correctly that as we face a shortage of providers or physicians in the space, one way to scale their abilities are to make their jobs easier,
Mhm.
right? So if you take the same number of people doing a job in a certain way that requires a tremendous amount of work that's outside of clinical, then you're actually not using them either, as we call it, at the top of their license, or we're asking them to do tasks that aren't required, with the education they have. And so I think scaling the workforce with data is incredibly important. And we focused a lot, I think, on the clinical space to, have impacts on education, learning, ongoing understanding. But I think the one space that's still relatively untapped is this notion of workflow efficiencies.
Mhm.
The productivity world, and the purpose of kind of our conversations around productivity are really to take important data that's always been available, but aggregated in a way that is understandable, and to try to understand market forces that are out there in order to enhance the patient's ability to see the right physician at the right time, and also allow systems or groups to understand kind of what the market demands, to understand their patients better. That's where I think the intersection of kind of the data sources that you bring, LexisNexis, and the interpretation and operationalization, how's that for a word, of the two together, I think, really is what makes us a relatively unique product, I think.
So the two of you bring up an interesting question. Adam came at it sort of from the outside in, Mike from the inside out. Having spent my whole life in healthcare, we are drowning in data. There's more data in healthcare. There always has been, but you can never make sense out of it. And so, I think one of the big shifts has been the ability to visualize the data in a way that addresses a problem, assists doctors to work at the top of their license, etc. It's that ability to take a 50,000-foot view and bring it down to the care setting. Because Mike, you're absolutely right. If we don't have, if we don't have physicians working at their productivity levels, and I'm talking about at the top of their license, it's just going to exacerbate the whole shortage that we have. And it's going to make it impossible for patients to access the care they need. So having said that, I think Doctivity is one of those innovations that has been able to visualize data in a way that now enables people to make good decisions. I know Mike used it at Geisinger to look at productivity of his physicians as well. I mean, what other sort of things? You talked about workflow, but we need to be working and walking in step with LexisNexis in terms of where you're going, in terms of the next innovation. Is it physician productivity like Doctivity? Is it going massive scheduling systems that scan the system based on that person's diagnosis? Where do you think are the greatest opportunities in the next 3 to 5 years, Adam, for your company?
For our company, we see a couple of things. We see one is being able to contextualize data through guided analytics, right? And the reality is anybody can throw data over the fence, but the ability to contextualize data that is timely, that is focused on what's happening right now, that is contextualized for the user, so it's driven by the persona of the person looking at the data. What do I usually do in my daily job? So that I'm not digging through data, but data's coming to me. I'm being proactively alerted, warned, having my attention drawn to things that are critical. But also, the reality is we know the next 3 to 5 questions that are going to get asked on any metric and any outlier at any time. So next best action predictivity, which is where you're seeing a lot of the Gen AI push come now, which is being able to talk to your data. So rather than going in and looking at something that's a flat report, can I get some guided workflow around what to do next? So, hey, we found, you want to pick up where you left off yesterday. Yes. I see there's some outliers I want to alert you to. You want to explore them. Yes. And then the next step is, what should I do with this? And here's 3 suggested actions to take on these 3 items that are outstanding. So I think that's one space where we're moving data to answers, right? And so I think that's contextually with data analytics and insights and even AI-driven analytics, you're seeing much more of a push to answers rather than go wander and navigate through data. And I think on the other side for us, it's been very much a focus on identity, especially as we're moving into a telehealth virtually driven world now. The reality is the only way to scare at this point is to start to Mike's point, is move some of the process around back office and workflow into automation, self-service, and then let providers practice at top of their license, do the work they're supposed to do. And so that's going to be more and more. I sort of think about it as healthcare looking more and more like the way call centers did in the 90s and the early 2000s, where this was my job as a technologist. We wrote early IVR, text to speech and speech rec, which was to take live minutes off of phone calls. So instead of a customer service phone call taking 8 minutes, we drove it down to 3 by front ending it with an IVR. And so you would ask the person calling what they were calling about, you'd verify their identity, you'd ask them some qualifying questions, and you'd route them to the right team, and the call would go from 8 minutes to 3, and the person on the phone would only do the things that a human really needed to do. Similarly, in healthcare, we've asked nurses and docs and all sorts of other folks to do a lot of clerical care. I like to call it. It's not clinical care; it's clerical care. I'm a nurse, by the way. I should remind folks to do clerical care and not do clinical care. And so, what can we do to start to offload that work? And it comes down to identity management. I need to know who you are. I need to be able to offer you a persistent credential. I need to be able to load that credential up with some critical data about you so you can work through the process faster. So rather than have you show up at a facility, fill out 20 forms, validate your identity 16 times, move through each part of your visit to a hospital with more and more forms, and also on the other end of that, asking nurses, docs, clerks, and other folks to collect that data. We should be able to move into a more digital space here. So on our side of the house, we are a data company, but we're also an identity management company. So we do both ends of this, and our focus is, all right, well, how do I ensure that in this transition from analog to digital relationships with health systems, we can help patients and their families and members all make that transition gracefully, and then offloads a lot of that work from providers. So I see that as a huge uptick in opportunity as we go forward.
Can you adopt Sussex County in Delaware as a beta site for?
Sure. Happy to.
Okay, thank you.
We're happy to work with anybody who's excited about
Mike, you were the early adopter for Doctivity Health. So you're sitting in the chair of the medical director for the Musculoskeletal Center, and you're facing a lot of different problems or challenges. You've got productivity issues. You want to grow volumes. You have capacity. What did Doctivity and that data bring to you that you didn't have before?
Well, I think the first thing I would say is it became very quickly a trusted source. I think the first problem in bringing data to physicians, clinicians, administrators is that the initial response is that I don't believe the data, or the data is not true, or my practice is different than everybody else's, and all of a sudden, then data becomes irrelevant. I think that recognizing that it has an attribution credibility to the point where you can say what they're presenting to me actually has real impact and can bring me understanding of my market is the first step of everything. Once we got past that, then you create a series of action steps around the data. And so for us, with regard to productivity and the standard things that we would do from building a business around musculoskeletal care, understanding our market with regard to the referral patterns, attribution of those referral patterns, and then enabling our teams to go out and make and address real-time solutions for when those occur. So, the simplest example is, getting data from our referral sources and noting that in the month of May, we saw a drop by one provider or another. Well, we knew immediately who the provider was, where the referrals were going, and we were able to go in and say, hey, what did we do wrong? And turns out, they were, in this one particular case, they were upset that they weren't getting some of the notes that we needed to send them in order for that primary care physician to continue to follow. And that was quickly rectified. So immediately resulting in a single step solution for that. Beyond that, I think as we've evolved kind of our understanding of the data, it actually rolls into, enhancing the patient experience. Because, the reflection of the patient experience is through the eyes of the referrer.
Right.
And so when you hear that certain things could be better or certain things could be enhanced or a patient could have an easier time doing X, Y, and Z, it impacts everything that we do. And I will tell you that we had zero insight into any of those things. And so, it's an evergreen process to bring good data in. It takes some effort to be able to use the data appropriately, but once you have it kind of on autopilot, the branches just keep growing in terms of what you can do with it. So I think it starts with trusting, creating a trusted relationship with the data that you're seeing, and then learning actually from others who may have been using data in a similar fashion to create best practices around how to enhance practice. And so that's what I'm seeing on the front line. And that's why as a leader within our institution, I continued to broadcast that this is important, not just for orthopedics or for musculoskeletal care, but basically every service line with our institution to kind of empower leaders to be able to make changes and take actionable steps to enhance their practice.
Absolutely. I've been in healthcare my whole career, and it takes a physician champion to advocate for a new system, a new process, whatever. I mean, and so you were that physician champion for us at Geisinger. But what do the two of you see at other health systems in terms of barriers to health systems either not using the tools or relying on the same old tools? I remember working in California, the data was 2 years late, to get to you, and that's impossible to work on. So what's happening now with the leadership around the country in terms of willingness to adopt either new ways of looking at the data or new systems like Adoptivity, to really grow their businesses and to thrive? Because we are going to have less of everything going forward.
Yeah, Adam, I'll take that first. I would say that what I'm seeing across the country is a kind of a generic step to say that you're one big EMR or you're one big affiliation with a large corporate entity, and I say this in quotes, they can do that,
Hmm.
right? And so, to me, it's a lot like accepting a weather report from on TV with a weather person that says, over here, you're going to get rain, versus something like an AccuWeather or something digitized that tells you within, a specific coordinated geographic point, it's going to look like this.
Hmm.
And so what I see in the marketplace is a lot of people who get a lot of weather person data. In this zip code, there is this opportunity. And I think the state of the art is, okay, well, then we will mobilize forces to attack the zip code versus saying, I have a GPS for where I'm going to apply my resources. I'm not just going to look at a zip code. I'm going to look at a street address, right, in order to deploy. And to me, that's far more efficient and far more successful in trying to achieve results. I think the challenge is breaking people out of the larger economy of scale conversation, which
Yeah.
says, I've already paid millions of dollars for this particular software solution that does a really good job on this thing, and it has a little bit to do with that thing. But because I paid for it, I'll use the,
Right.
or half opportunity, rather than linking into something that's much more granular. I'm hoping that we're in a trend that has reached its limit. I think that we're getting to the point where this kind of one solution fits all has been driven largely by system performance, finances, COVID, all of those things that have hit. And we retrenched significantly. At our institution, many institutions, we went from 12,000 software programs that touched our system to like 4,000 in a rapid pace, which I think was the appropriate right sizing to do. But as you get closer, and forgive the orthopedic analogy, as you get closer to cutting to the bone, right, you've got to make sure that there's that you're not diminishing your ability to do the really important things that could be bespoke, and those things are inclusive of important elements like productivity, right?
Yeah.
Understanding your market. I hope we don't cut too close to that. Unfortunately for us at Geisinger, we've taken that opportunity to use a bespoke type of software process using data sources that are not necessarily conventional to what we usually do, in the face of a large number of other suppliers of information, and head to head and side by side and saying, let's go head to head with what we're getting from this company and what we're getting from this company. And then understanding, that we're getting better data. It's like, putting on a pair of glasses that are half prescription
Yeah.
and saying, I can see, right? There's a human over there, or, getting the clarity of, the right prescription and saying, oh, I can actually see what they look like. And I think when you do a head-to-head side-by-side, I've been very impressed by kind of the work that Activity is doing, because I don't think we've lost a single head-to-head
Mhm.
in that process. So, to me, I think that speaks volumes.
Well, and Adam, I want to hear your point of view too, but I've been on a number of the demos, and one of the good housekeeping seals of approval is when we mention our relationship with LexisNexis. It's got a solid brand in healthcare, and people know that they can rely on the data. And the partnership has done us well. But when you send your folks out into the market, what are they coming up against in terms of health systems' willingness or unwillingness to adopt or change, like Mike was saying?
Well, I think you have a couple of forces at play. I agree with Mike wholeheartedly, but I think the thing you note is every time a large management consulting firm does a national survey, the top two things you'll see in there about executives and what they think will be critical to their future strategy is data and AI.
Mhm.
And it's increasingly now AI and then data. And it's generic, but to the point made, everybody consolidated their systems and they're going to have to, again, we're going to go through another loop of vendor consolidation because of budgets. Right? And so this always ends up with cost cutting measures and people making, I would say, practical decisions that aren't necessarily always performant. And the large scale EMR one system approach to things has also created sort of an also ran capability where, EMR systems have to provide a little bit of everything, but they're not going to do the deep dive or specialization that you're talking about from a capabilities perspective. They do some of the things and sometimes it's good enough, but if you want to get into the detail and you're really trying to drive programmatic application, you're going to need something that offers a better view. The other critical component is they also only point to internal data. And so if you want market data and you want to see the data outside and adjacent to your system, the next adjacent market, you want to look at comparisons of similar market size, you want to do any sort of national review, anything beyond just your system, you're going to need external third-party data. It needs to be clean and it needs to fit into your ecosystem well. And I think the place where we partner pretty well with Doctivity on providing that third-party view that actually gives you a reference set to compare against, but also gives you sort of that honest broker of real third-party data that, like you pointed to earlier, that attribution is correct, and you're actually saying, "Hey, this data is validated and it's used in a ton of processes, and it gives you a national standard." I think the other piece of this that we're starting to see now as folks go down this pathway, it's all right. As I think about vendor consolidation and process consolidation is, how do I optimize the process and my cost point? Just pragmatically, you're seeing now with the overlay of AI, we're going to see less customization in EMR systems. So where you used to see these multi-billion-dollar implementations of large-scale EMRs with these large consulting firms that would drop 100 or 200 or 1,000 people to do implementations, you're seeing overlays from folks like Microsoft and their AI companions in this space now, where you can build AI overlays for EMRs, and you no longer have to customize the workflow. And so I think that combined with good analytics tools is actually going to change the face of this software, and that's coming. That's GA stuff that's out in the marketplace from Microsoft, and not to continue to talk third party, but if you look at what they're doing from an innovation perspective, they onboarded a natural language voice recognition software. They put some ambient listening together and they built a way to interface to essentially any software package. You can reface your entire EMR with a couple of AI modules that listen to your conversation with patients, prompt you with the common tasks and workflow that we'd like to reduce, and change the landscape. That's not analytics, but it certainly changes the front end of that. And now you're really talking about a different space where the structure of the EMR is no longer a boundary for how we deliver care. And so if we start rethinking it that way, we should also be rethinking about how the analytics end of this works, which, to your point, Mike, it doesn't need to live in the EMR. It doesn't need to live in a tightly bounded space. We just need to be able to collect data effectively from there and get it into an ecosystem that does work. But what's the feedback loop now that we have to start talking about to the AI from that analytics space to start to drive better decision-making in AI and better support and be better behavioral modeling? Because effective AI says, I know Dr. Mike, I know how he likes to run his practice. I'm going to prompt him with the kind of tools from a data and a process perspective, just like I would in the OR. Here's the kind of things he uses to run his practice. I can anticipate the way he writes notes, the way he refers patients, the kind of order sets that matter to him, and the kind of contextual workflow he's going to want for support for managing a patient of this type who came in for a second follow-up visit. Well, that should be a standard visit, a standard process, right? And then the analytics loop needs to feed back to that space to say, hey, the referral patterns associated with your patients post that visit aren't aligned to our expected standard, or you're seeing longer turn times, or you had longer discharge dates, and be able to alert you early on some of those things to say, hey, there's a trend in your practice that's changing. So anyway, I get excited about that end of it, but I think there's an opportunity for us to rethink, like, is the EMR now really as bounding as we think it is? The answer is probably no. So that means that as we rethink plugging things into this ecosystem, it shouldn't all be in one box. It should be, well, I have to deal with that box because it was implemented, but I don't have to live with it the way it was implemented, which is a very interesting construct, and it really sort of changes the way we think about software.
Recently, I had a conversation with Kathy regarding someone we were talking to relative to, as someone who was head of marketing, you'd get this thing from finance telling you needed to increase volumes by 5%. And I always would say, is there 5% out there to get? We didn't know anything about the market. We were fitting a number to a bottom line, right? And now it is so inverse. And so what happens is the people who used to have the claims data was strategy for doing that kind of work.
Yeah.
Now it really needs to be marketing, and it needs to be the medical directors of the service lines. Now, Mike, you took the data that you had, a real life situation. You had, was it productivity and volumes you wanted to grow?
Yeah.
And
I mean,
you
I
took the
think-
data.
Yeah,
Tell us
and
how
our-
you did that.
Our early experience, and again, this is the test of truth, right? When we engaged in the initial pilot to use Ductivity way back when. I mean, I'm a skeptic by nature, and despite the fact that I've known Kathy a very, very long time as a great friend, listen, we weren't going to put our money unless we actually saw that we saw results. And I would say that after the initial pilot of what we did, we saw a 36% increase in productivity and volume combined in the first 6 months of using the tool.
Wow.
I mean, that's return that I think is relatively unheard of in what we do in healthcare when health systems are fighting for, a 1% margin, to survive. And with that level of immediate knowledge and change in terms of how we can change practices, referral patterns, and increase productivity volume was enough for me. It was enough for the system. It encouraged us to be the first adopter, or at least one of the earliest adopters. And since then, I've been only speaking highly of it because I haven't seen, those results reversed anywhere else, right?
Yeah.
So it's not like I have another colleague or another system that's used it and said, "Oh my God, we went backwards." I mean, the conversation to me is fairly simple, right? When you get into a question that goes beyond does it work, because it works, and then you get into the granularity of is it worth this much more, or is it worth this investment? To me, I think the answers are pretty simple. You're getting much more out of it than you're putting in, and it works.
Yeah.
Adam, to your question, to your point earlier, I love the way you contextualize, the world of our future with EMR. I share a lot of the same beliefs. The one size fits all notion, this idea that the EMR is the answer to everything. I think we're showing lots of areas where there's weakness in the EMR. We see a sunk cost fallacy that occurs constantly, in that I put this much money into it. I'm going to keep putting money into it because I've already put this much money into it. And Jane, to your earlier question of what is it that is challenging to bring in new systems, I think it's related to that.
Right.
And so you can look at, when the truth comes out and says, look, this works, it gives me answers and it increases my productivity value, but you know what, I'm not going to buy it because I've already put money into the thing that's not giving me those answers.
Right.
To me, the behavioral psychology of health systems and some of this decision making is beyond confusing to me. And it goes to what you said earlier, Gene, about having the right surgeon, the right physician, right somebody champion to point out that sometimes the emperor doesn't have any clothes.
Absolutely. And
yeah,
you also brought up a point about when referrals fall off, you went and found out why they fell off. So
Yeah.
how have your physicians in your division responded to that, particularly when they're part of that problem?
Oh, sure. I mean, yeah, it's amazing. It's an epiphany in many ways. I mean, very few people that I've met in healthcare, react to feedback they get from patients and referrals in an overly negative way, Right. So if I hear the primary care physician is upset that they weren't getting their notes back, I don't turn around and say that's your problem. It just doesn't happen in the natural course of business. And so the docs, when they find out that there are issues or there was an issue, I mean, they're on the phone. They're trying to figure out, what is it that we did? Sorry for this particular event.
Yeah.
How do we make it better? Right? Let's rekindle that relationship type of thing. We work with our teams that do that kind of reconnaissance as well. So the reaction has actually been overwhelmingly positive. I've not experienced, and it's rare to ever hear of an experience where you hear a physician, a surgeon, turn around and say that, I hate the fact you gave me good data. It just doesn't happen, right? And so
Well, you guys are wired to the scientific method, so data is in your backyard.
right. Well, I mean, we will question the data endlessly.
Right.
When you get to the point of trusting, and that's what I said at the beginning, right? Nobody turns around and says, "Get that good data away from me because you're ridiculous." I mean, it's like we love it. Just feed us more.
I agree. I agree. Um, Adam, if you had a magic wand, I love this question. I always give this question to people when I do a panel. What's the one data problem in our industry that you would like to see solved? I mean, that's a really big question, I know, and we got a lot of potential candidates, but what do you think is the big gaping hole that we really need to close?
Well, it's really two things. First is, we finally got to some standards. So FHIR is actually a standard, unlike CCD and CCDA that we had before, which were sort of standardless standards. Finally got to a standard, but there's no minimum data set. There's FHIR, and there's the full FHIR standard, and there's USCDI, which is used really. It's like the EMR to your point. When they were built as billing systems, not as care management systems or care delivery systems. So we've stuffed a lot of things into the box, and I think the same thing was done with FHIR. But a minimum data set for either providers or patients, but I think more so patients and healthcare plan members, to have some portability of their data that actually serves them as opposed to the industry. Right. This is not, we're all working the industry, so I'm knocking us. But we've never taken the opportunity to educate patients and members and families about their care. We know that in health equity, one of the biggest barriers is health literacy. But if I could give you a data set as a patient or a health plan member that you could carry around with you in your wallet that said, look, this is the critical components about me. I almost think of it like a life alert bracelet. Right? Here's what you need to know about me as a patient, health plan member, household member, that will help you give me care, but also we can provide them with some patient insights about what it is in their health wallet so that they understand it. So that it's driven to average reading level, it's common language, but also it offers that patient, well, these are questions you should ask your provider. Here's what's coming next for you in your care. And oh, by the way, if you don't understand this test, here's a link. Here's a way to have a discussion with your provider where the provider can send standard information to the patient's health wallet, for argument's sake, and it gets translated to their language reading level orientation to their healthcare. But that idea that we create, I don't call it magic. It's not magic. We have the technology at this point, especially with Gen AI, to create health literacy for our patient population, because, and you know this as a physician, Michael, the information gradient, provider to consumer or to patient, is miserable because the patient always knows more about what's happening in their world than the provider does. And you only get to touch the tail or the ear or the trunk of the elephant when they're in the office with you. And then the rest of the time, you have no idea what's happening for them. So there's an opportunity to change that gradient by opening the door to conversation between the clinical and non-clinical parts of this business. And I think health literacy is the part. So making that data available in a form that everybody gets to use, I think it would be a really interesting term. And you're seeing bits of it. We own a company called Human API, which is a patient-mediated EMR access point, which essentially allows patients to share their data. but no one's walking around with it. And I have an Android phone. I'm sure some of you have iPhones. There's a health wallet on your phone, but we don't use it in the way that it is imagined. So I think in this era of Gen AI and in this era of data access and ubiquity, that's the next one is what's that bit of data that would make your job easier in treating me if I showed up in your office and would make my ability to be compliant with pre and post care better. What's that data set look like? If I could magically wave a wand and say, this data set solves all problems. Ding, thank you. It would be that. Is to find a couple of overlapping sets that actually work on both ends.
Yeah, Adam, I'm going to jump in real quick. I love the way you've kind of, portrayed or at least discussed the issue around equity, and literacy. You also did it in a way that actually talks about the patient journey, which I think is really interesting. And I share a lot of those same sentiments. I think when we think about the application, and this is your magic wand question, Jean, I'm sorry to jump in on this one.
No, I was going to turn to you anyway.
When we think about, the potential interventions based on kind of the trajectory of what we see in terms of technology, AI, first of all, we recognize that it's happening at a pace that's unreal, right? And like shockingly unreal. And people talk about it with regard to labor, workforce, redundancy, eliminating positions, eliminating jobs to create an agent somewhere along the line. I'm really excited to see what that will bring. But I think that it actually offers us the opportunity to look more carefully at the patient journey, right? As you said. So, the questions like what happens between visits is critical, right? So I'll operate on somebody, I'll see them at 2 weeks after surgery, I'll see them at 6 weeks after surgery, and I'm hoping they're doing their physical therapy and, they're calling my office every once in a while, need a refill or something. And, these are, spot moments in time for a patient journey in an acute episode. But that real-time evaluation and kind of, I think the feedback is part of our future. Right. And it doesn't have to be necessarily that they speak to the surgeon every 5 minutes or every 30 seconds, but there is an agent involved that helps them manage the most commons. And I think that is actually part of our future, in order to help manage the populations and also acute episodes, and I think this is all part of that same context, right? What we're talking about with activity as a first step, with LexisNexis and its data sources. But I think that, the future, if we keep iterating on these ideas, starts with your understanding of kind of your market, understanding the needs of the patients within that market, and then watching it just continue to grow, all within the context of what I hope will be a downward trend in saying one size fits all. That may be not be now, but I certainly know it's coming because of this rapid explosion of all of the competitors in the same space that are doing the same thing and iterating on each other. And I mean, we never thought that when ChatGPT came out, it was like everyone jumped onto it because the only one. Now there's like 15,
Right.
right? And I don't know what to pick. I just, I paid for one, so I'm sticking with that one. There's a whole business model question around that, but I think that all happened within the last couple of years.
What
Yeah,
makes
and
me
it's only
smile?
accelerating. Yeah, I was going to say it's only accelerating, and as you're seeing the micronization of models and the cleanup, DeepSeek was the really good one. We showed that you could do something that was fantastically expensive for far less money with a far smaller footprint. And as things get shrunk again, right, this is what always happens. You build magic technology, you make it smaller. And now, as we get into that arc, to your point, it's going to be everywhere. It'll be embedded on your phone. It'll be embedded in every device you have, and it'll start localizing, and it'll become more democratized. So you won't have to pay. It'll be a free model that's embedded, and then you'll have more of the premium features as we go out. But it's just gonna continue to get embedded in daily life.
So let me ask you from your individual purchase as a vendor and as a practicing physician, what would be your advice to a healthcare organization who says they want to get more data driven in their decision making? I mean, what would be the advice you would give them in terms of how to really jumpstart that?
Well, I spent years and years and years as a consultant in warehousing analytics, digital transformation for customers. And the first question you always ask is what questions are you trying to answer? Because the vague hand wavy, we want to be a data-driven company, is a dead end, right? People cast about in all different directions, and you don't ever have any real focus, and there's no orientation. So question is, what questions do you want to answer that you're struggling to answer? Either they take too long, to your point, there's lag on the data, there's not a real definition, or you truly don't know where to start for critical questions in your ecosystem. And then what will you do with the answers when you get them? Which is the next question. What's actionable? That's usually where we start. And then it's a survey of, are you using all the data you have in-house, or are you treating it like runoff and exhaust? And then the last question is always, and it's where we come in, which is what's missing? And what's missing either from a data or from partners like Activity, what's missing from a technology and a process and consulting perspective to close the loop. But it starts with, what are the questions you're really trying to answer? And then what are you going to do when you get the answer? Because if I give you a question and answer and you have no ability to influence the outcome, it is a waste of a question. It's a waste of time and energy. And it's really just a poster to put on the wall, just like the hanging kitty that says, hang in there. It might make you feel better because you know the answer, but you're not really going to change anything with the outcome. So we really focus on that idea of actionable data all the time. And having a clear pathway for action when you can calculate and certainly determine something, push in a direction.
Mike?
Yeah, I think your question was, how to, if I was a health system trying to make decisions or trying to decide that I wanted more data to help make me decisions. I would say that you look at the landscape of who can provide that information and that you challenge them to, demonstrate their value. And I think that companies who shy away from that, I think are not companies you want to talk to. I'm confident in the work that you guys are doing at Activity because, when challenged, you step up. And so if there's a health system, that's saying, look, I don't really know, you're a separate company, you got, good data, but I don't know if you can back it up. I would say challenge accepted, and go try to figure that thing out, because that's the only way that we can get past the promises of all of what's happening. So another phenomenon, right, in this gigantic tech space is that, in many ways, it's like medicine from the, 17th century or whatever. Lots of people say, I got the magic cure for you. It wasn't until we brought rigor to medical education to say that a lot of these snake oil salesmen, as we used to call them, didn't really have anything behind it. And I feel like we're a little bit like that now in the tech space. You've got, anywhere you look, if you have a problem in healthcare, you'll find someone who's got your solution. You have no idea, right, whether or not it's actually, going to be backed up. And so there's going to be some rigor, and I think some standardization, maybe some intellectual rigor that's associated with how you approach these things. But until then, I think the best thing you got to do is follow the outcomes.
I think Tom is busy undermining my investment in leeches. She's bought a leech farm, and Tom is busy undermining it again. I'm sorry, Mike is busy undermining it again.
Wow.
Yeah.
We'll have to have a separate conversation about your leech farm, but
What's old is new again. That's right.
Got that about the 17th century. I thought of leeches and
Yeah,
people. I was
just letting.
Hey, look, no one ever said to you, I'm really getting big into leeches. I'm leading the charge.
no.
So, Mike, if you want to get on board, I'll talk to you, bro. Tom, we'll hey.
All right, I'm in.
You heard it here first, ladies and gentlemen.
Yes.
We'll get a QR code out at the bottom of the screen
Yes.
later on so people can get in touch with you.
Just I won't bring any table salt with me, I promise.
That's right. Leeches, blue turmeric. You heard it here first.
Well, gentlemen, thank you very much. This was so interesting. I think we could just sit by the beach and have this conversation for hours, but our time is done. Ladies, do you have any other questions you'd like to pose to our guests?
No, that was wonderful. Thank you both so much for joining us today.
It's been a pleasure. And Adam, it's as we've been discussing, it's wonderful to be in a strategic alliance with you. And, again, to Dr. Sook's point, when we're in the consideration set with health systems, it's always that we do the old Pepsi challenge, and the data that we validate is what allows us to continue to grow our business. And we've just really enjoyed your our time with you today. So thank you very much.
Well, we're happy to partner with you. Thank you all.
Thank you, guys.
Have a
Thank you,
great day.
Bye-bye.
Bye bye.